Good evening and welcome to our webinar tonight, the current and future state of ED and how primary care can help. My name is Jenny Pearson and I'm an Education Officer for the Primary Health Network. Before we go any further, I'd just like to acknowledge the traditional custodians of the lands that we meet on tonight and pay respect to elders past, present and emerging. This webinar is being recorded and will be available in our education library. If you have any questions, please type them into the question pane. We do have a question and answer section, which will be at about 7:40. But when we play Kate Jardine's presentation, Kate's actually on holidays this week and very kindly recorded her presentation on Friday. We will be doing a Q&A session straight after her presentation. We have Dr. Nicholas Whitehead here to answer any questions about her presentation. We're very lucky tonight. We have an array of specialists to present for you. Our first presenter tonight is Dr. Christopher Jenkins, and he's an ED physician at John Hunter. So I'll just make you the presenter, Chris, and you can share your PowerPoint.
Thanks, Jenny. All right, that's coming through?
Yes, it is.
Excellent. All right, so thanks very much, everyone, for coming along. I just want to, I guess, by way of last time I gave one of these talks was a long time ago, and I think I misjudged the audience. So I want to make sure I don't do the same thing tonight. So my impression from the last time I gave one of these talks was that the majority of people who turned up to listen were not necessarily the group of people that my talk was targeted at. So when I previously gave this talk, we were talking about patients who came to the ED on lots of medicines and had lots of interactions, and we ran a quality project with one of the pharmacists in ED where we fed back to some of the GPs about the prescribing of certain medicines that had interactions or contraindications. And when I presented this data to a similar group, it became very clear to me that the people who turn up to these sessions are not the sort of people who need someone else to point out how to go through and check patients' medication. So I just want to say that I may be preaching to the converted here, and the target audience it may not be the people who've dialed in. So if I do overstep some boundaries, please let me know, and I apologise in advance. So I wanted to talk about some of the immediate challenges for the emergency departments in the current environment, with the restrictions ending and with COVID likely to continue to spread in our community. I thought I'd just start by saying where the current COVID situation is, and this is as per about an hour ago. We have 1,188 active cases in the Hunter. There's 4 in ICU, only 19 in hospital, which is quite interesting. But there is 851 people still in the care of hospital in the home. So you'll see that those numbers don't quite add up to 1,188, and the reason for that is some patients will are coming towards the end of their 2-week period of home isolation and are well, and hospital and the home have discharged them from their care. And there's also a gap between when people test positive and when hospital and the home get a chance to contact them. And at the moment, that gap's sort of blowing out to 3 to 4 days because the hospital and the home service is getting pretty overwhelmed with the number of COVID positive cases that are coming in. So interestingly, compared to what was going on in Sydney, particularly in Western Sydney a few months ago, we're having less patients admitted to hospital and less to ICU, and that's probably a result of 2 things: that the vaccination rate has increased considerably since when the outbreak began, and it seems to now be predominantly young people. So nearly 90% of cases are in people under 50, so where the risk of serious illness is a lot lower. So I think that's helping. But as you can see, we're the only area within the state now that is continuing to see an increase in cases. The replication rate's 1.09, so anything above 1 obviously means that case numbers are growing. and the state average now is 0.89, which means that the rest of the state is all going down and heading in the right direction. Interestingly, every patient who currently has an active case in the Hunter is unvaccinated, which is probably not surprising to any of you. So, one of the challenges we're facing at the minute in all the emergency departments is an increase in presentation. So over the last financial year across the entire LHD, our emergency departments had a growth in presentations of 7.8%. It was 8% at John Hunter. And that's put considerable strain already onto our emergency departments. That's a significant amount of growth. A little bit of that is a correction because the year before was slightly down on what was predicted. But to give you an idea, we've been tracking along at sort of somewhere between 3 and 5% over the last 5 years. So it's a significant increase in presentations. We did have a little bit of a dip when lockdown began, but we're rapidly returning now to high numbers of patients. And on top of that, we're now starting to see more and more COVID patients coming, and that is going to continue to be a problem for us. They're incredibly time consuming, just with the issues around PPE, with the cleaning of the rooms. And in fact, the biggest problem we have at the minute is patients who are COVID positive turning up who are actually well enough to go back home is we can't actually get them home anywhere without organising specialised transport for them. Although we're working on a solution to that problem, we obviously can't call an Uber, and their family who are under strict instructions to stay home aren't allowed to come and pick them up. So we end up accumulating these patients in the ED, which means we can't offload any more COVID patients because they're taking up all of our isolation beds. As soon as lockdown ends, the same as we saw last time, we'll see a huge surge in patients with respiratory symptoms, particularly children. And we're already starting to see that. And we understand the complexities around seeing patients with respiratory symptoms in general practice, and I completely understand that. People are running a business there, and to have all of their staff out for 2 weeks because of an exposure is something that's very challenging to manage. So I think we've learnt that we will be seeing those patients, and that is understandable. What we are really struggling with at the moment, though, is we're seeing about at John Hunter, Belmont, the Mater, Maitland, we're seeing about 25 to 30 patients a day who are coming post-vaccine with vaccine-related side effects. And my big concern with that group is that a lot of them are coming after their first vaccination dose, and they're presenting within 2 weeks of having that dose. So they've probably not got any significant cover from that vaccine at that stage. And they're turning up to the emergency department where now that the restrictions have ended and our patient numbers are going up, the biggest problem we'll have will be working out, it's pretty easy to work out the patients that we know are positive, and it's actually reasonably simple with the patients who we think are positive. But what we're going to start having turn up to our emergency department is people who have minor symptoms or are relatively asymptomatic who are actually presenting with something else. They've sprained their ankle, or they've got abdominal pain, or whatever. And trying to keep everyone separated and manage that risk is going to be very, very challenging for us. And my fear is that we're going to have 25 to 30 of these patients turning up who aren't covered yet by their vaccine, coming into that environment and potentially getting exposed. And that's a real risk. And I'm going to make a plea for everyone in general practice to try and help us with that. It's a challenging problem. A lot of patients are just turning up. If you get onto Health Direct, they have a vaccine side effects checker, and having played with that myself today, it's very hard not to get sent to hospital, it seems. But that is a real challenge for us, and we're really hoping that's something that general practice might be able to help us with. The other issue we have is we're seeing a surge in mental health presentations, which there's an enormous amount, I think, of underlying anxiety in the community. Part of that's just the community, and part of it is related to COVID. And we're seeing a kind of real surge in that presentation group, which again is putting a lot of strain on us. We need to see those patients, obviously, but it is getting very challenging. So we're worried that we're going to get overwhelmed. That's our real concern. And when we do get overwhelmed, that will mean that patients will inevitably wait longer. The waiting room and those areas will become more crowded. It'll be much harder to keep people socially distanced. And when we won't really know the risk of everyone who's turning up there, that's going to pose some real challenges. We've had lots of discussions about rapid antigen testing everybody who turns up, and that's been done in some places in Sydney, but that's a challenge for us to work through. There's some competing ideas about that, but essentially that would mean we would test everybody in a tent out on the front lawn, and only once we knew the results of your test would we let you go any further. And obviously that's a huge inconvenience to patients. It's a huge cost to the health system, but it may be the only way ultimately we can separate all those people out safely. So I'm making a little bit of a plea for help. A lot of those patients, particularly who are coming with vaccine-related side effects, some of them are self-presenting, but a considerable number of them are presenting via general practice. And we're really hoping that those patients are, I think, people who the risks are actually really low of having a serious complication after the vaccinations, and I'll show you some slides on that in a second. And I'm wondering if we can try and see if those patients could, wherever possible, be managed in the community rather than coming to the ED and potentially risking exposure when they're not yet adequately protected from their vaccines. Some of those patients may still need to come, we accept that, but we'd really like some help in trying to minimise that. The other area I'd like to point out that's becoming an issue for us is that, and again, I think this is probably only a small subset of general practice. I suspect everyone listening doesn't do this, but we're seeing an increasing number of people who, because of the COVID situation, have had their outpatient appointment for their chronic abdominal pain with the gastroenterologist, put back by 6 or 9 or 12 months. Patients who've been waiting for their knee replacement who've been also put back by similar time periods. And we're seeing quite a lot of those patients presenting to the ED, hoping that we can somehow facilitate those appointments or operations for them in a more timely manner. Obviously, that isn't something we can do. And in fact, we would, even if we could do something about it, it would be something I think we would be very reluctant to do, because if the word on the street became turning up to the emergency department got your knee replacement done sooner, we would be in a very challenging situation with lots of people turning up expecting the same outcome. So we can't influence it, and I would suggest that if you have patients who have been waiting for a long time and their situation has changed or something acute has happened, then by all means we're very happy to see them in the ED. It's just, if it's just that they're continuing to have the same symptoms and they're still waiting, then I guess contacting the people you've referred them to and asking to reprioritise them is probably the only thing that I can suggest may help those patients. And as again, I suspect most of you would already be doing that, and I think it's only a small subset, but we are seeing an increasing number of patients who are turning up saying that we were advised if we weren't getting any better or nothing had changed to come to hospital. And again, we're fairly powerless to help those people, unfortunately. So what I'd like you to do, if it's possible, and I'm really pleading here, is that if you, before you send someone to the ED, you obviously already make a risk assessment about whether they need to come or not. But I just want you to add into that risk assessment that the difficulties we're going to have with keeping people separated, along with potentially the long waits. And to give you an example, particularly with the vaccine side effects, I think it's really unlikely that any of us are going to see a significant number, if any, of these patients. So you've got a 4 in 100,000 chance of getting myocarditis or pericarditis after one of the mRNA vaccines, and nearly all of those have been mild and self-limiting. And you've got a 2 in 100,000 chance of getting a vaccine-induced thrombocytopenic thrombosis. And again, there's only been 125 cases of those Australia-wide up until yesterday. So I don't think the ED needs to see all of those patients with those side effects. I think the chance that any patient who turns up either to the ED or to general practice of actually having those conditions is incredibly low. And if they are well and they have normal vital signs, then I'm not sure that they all need to come to the ED, and despite that, a considerable number of them are coming. The other way you could help is we are looking at trying to establish a pandemic clinic. We're helping with patients presenting with respiratory symptoms and the screening and management of those patients. If anyone is interested in that, I know that a request has gone out to the primary health network to assist with that, and any assistance we could get with that would be great. Unfortunately, the ED probably has very limited capacity to help staff that. I think the whole hospital system has a limited capacity, and I think we're reaching out to the primary health network to see if anyone can assist with that. That's what I had to say at this stage. So I'll hand over to Mike, who was going to follow on from that presentation. Thanks, Jenny.
Thanks very much, Chris. Our next presenter is Dr. Mike Anscombe. Mike is the head of the Paediatric Emergency Department at John Hunter. And I will just bring up your slides. Just going to turn off my camera.
Okay, can everyone hear me okay?
Yes, we can. Yes.
Okay, cool. All right, thanks very much, Jenny. And thanks for that, Chris. I haven't got too much to add to Chris. Chris and I have talked, and I'll try and not say the same thing twice, but try and maybe reinforce a couple of things that he said. I was asked to talk about, I suppose, COVID from a paediatric emergency perspective, and as probably everyone knows from the media over the last 18 months, it really is much more of an adult disease, COVID. The kids have been reasonably unscathed by this, and I think what we're going to see over the next few weeks is hard to predict, but it's probably more likely going to be a problem amongst the unvaccinated adults. But I do think there's going to be an impact on the children by this potential surge in sick adults, and there will also be an impact from COVID in kids and possibly non-COVID related respiratory illness that may be unleashed as we come out of lockdown, which is going to impact on our space and staff as well. Just to add to Chris's information about the number of patients with HIF at the moment, of those nearly 1,100 people, about 150 are deemed high risk at the moment, high risk of needing admission to the hospital. 330 today of those patients are children, and that's they're predicting it to be heading up to around 500 in the next week or so. And it's fair to say both HIF services, the adult and paediatric HIF services, are pretty stretched at the moment. Perhaps almost overwhelmed the other day, particularly the paediatric service when they had 50 new patients on their books within 24 hours. It's very hard to keep tabs on all those people. So next slide, please, Jenny. Okay, one of the silver linings of COVID has been perhaps a little bit more speed with which things have happened. We've managed to extend our current ED to last through till 2026 when we get a new acute services building. Got a brand new paediatric emergency department or paediatric emergency area with 12 beds. This is what it looked like when it opened in August last year. It certainly doesn't look like this now. There's plastic sheets and flow and different colours everywhere, just sort of demarking where red patients go and orange patients go, and there's donning and doffing stations everywhere. So it's changed quite a bit. Next slide, please. Okay, so this slide's reasonably busy, and I'll take you through it slowly, but it sort of paints a picture of what's been happening over the last couple of years with children, where we're at now, and it gives us an idea of where we might be going over the next few weeks. So there's 3 squiggly lines there, each stand for different years. The x-axis is the year, or the 12 months, and the y-axis is number of presentations. If we start with the straight blue line to start with, that's a total of, that denotes 60 pediatric presentations a day, and that's sort of what we were seeing back in 2018. If we go to the red line, that's 2019. So this is the year immediately preceding COVID. And you can see over that sort of period that the numbers of presentations climbed from 60 up to pretty much 70 right through the autumn, winter and spring periods, dropping down sort of towards the sort of summer. So it was a very busy year. And then if we come to the black line, this is when COVID sort of started, 2020, you'd see that there's an increasing number of cases in the first couple of months of the year before we went into lockdown. I don't know what the numbers would have looked like had we not gone into lockdown, but it was certainly going above 80 and probably heading up towards 90 there. With the lockdown, you can see everything sort of very much calmed down, and we were seeing half the number of patients, with below 40 a day being quite normal. Then with the lockdown, coming out of lockdown, the numbers increased again, but I think everyone's social distancing and wearing masks, it sort of kept the numbers, particularly of respiratory presentations, under wraps for a bit, until there was this massive big RSV outbreak sort of in December, January last year, which was very challenging. If we come to the green line, that's this year, and you can see that the numbers have sort of inexorably climbed again with the autumn and winter, right up to where we're getting over 100 patients a day, sort of before we went back into our second lockdown in the beginning of August. And then you've seen the same pattern again, with numbers plummeting down to sort of around 40, but they're starting to climb back up now. And we're sort of predicting it's just going to keep on climbing, and we're just not sure how far it will climb. So next slide, please. Okay, so this, Chris mentioned mental health. I think the two groups that we've seen a big spike in with pediatric presentations have been our relatively well respiratory presentations, our kids with runny nose, coughs and fevers who traditionally would have gone to their GP, but have not been able to get into their GP a lot of times, have been coming up to the ED. So that's been a reasonably easy group to deal with, but certainly still time consuming. Everyone needs to be swabbed and has a history and examination, has some paperwork to go home. So all those kids do take time. But the mental health patients have been the other big group. These kids we were seeing from the blue line there, sort of 4 a day on average. But with 2019, it was starting to creep up pre-COVID, and then you see the black line there, it sort of climbed up even higher again with 6 to 7 a day. And I certainly had a shift where I had 17 come in on one shift. It was very, very time consuming. These patients are often have major social problems as well and take a long time to help. And the ED is not a very pleasant environment for anybody, let alone someone that's a distressed teenager, which many of these presentations are. In fact, of the mental health presentations we get through the John Hunter, over 80% are under the age of 18, so they would all be seen by us in paediatric emergency and by the CAM service. So I'm we traditionally see a lot of mental health patients come through on a Sunday night. That seems to be a pretty classic sort of time, and that's often pre-school. With school going back on the 25th of October, I think we're probably going to see an increase in mental health patients around that time, with the stress involved with that. I think mental health, I think COVID's affected everybody's mental health, staff and patients alike. Even the patients that aren't coming in with mental health problems, there's often a significant mental health overlay in the parents with anxiety, and certainly with a lot of the children are very anxious as well. Makes it much more difficult to do procedures and to assess them. That's just an observation I've had over the last 18 months. Okay, next slide, please. So it's hard to say what we're going to see over the next few weeks. It's hard to look at Sydney and go, well, they're ahead of us with the numbers of patients they've had, and therefore this is what's going to happen in the John Hunter. But they didn't really have, but they've had everyone under lockdown, so this is going to be quite different. So I think we're probably going to see medical presentations. So I think potentially a lot of well children with COVID who've got mild respiratory symptoms. We may see some sick children with COVID, including the PIMS TS Kawasaki's disease type presentation, although it's pretty rare. Like I said, mental health presentations with return to school. I think we're going to see a climb in those, and increasing difficulty to accommodate and assess and manage these patients through the ED as it gets busier. And a lot of the paediatric COVID-related issues, according to the paediatric health people I've talked to, is social rather than actual medical problems. Next slide, please. I think the other thing we may see is another surge of non-COVID related respiratory illness. We saw this obviously with the RSV epidemic December, January last year. Or December last year and January this year. When Perth came out of, or when West Australia came out of lockdown not long ago, they had a surge in metapneumovirus, human metapneumovirus, and I know the paediatric infectious disease guy that's running Heath at the moment wonders whether that virus may be lying dormant out there as we speak. So last slide, please. All right, so just if I could just reiterate that what Chris said, keep vaccinating. I think that's the best thing that anyone can do really at the moment to help reduce the impact on the frontline healthcare workers. As much as you can, think about what ED's core business is, and it's really looking after the significantly sick and injured. Anything that can avoid ED ideally should avoid ED. Again, the Pandemic Assessment Centre, I'm involved with the ED Disaster Group and the procurement or commandeering of that space and how we might use it. It's going to be very difficult for us to staff it in-house, particularly from ED or from medicine. Paediatrics may be able to help from a medical point of view, but I think it would be fantastic to have a bunch of GPs running this service from 10 a.m. till 10 p.m. at night. And it's really important to know that we've had plenty of COVID exposure through the ED, and with appropriate PPE, we've all managed to remain safe. So you'll be safe as well if you come and work in this service, I'm sure. And probably the other group that you could help with is HIF. I spoke to Sharon Ryan, the JHCH DMS today, and she said, look, she'd be very keen to hear from any GPs that may want to help with the paediatric HIF service. So Sharon Ryan, one contact, and for working in the pack, Leanne Johnson, the General Manager of the John Hunter Hospital, would also be very keen to hear from you. Okay, that's it from me.
Thanks very much, Mike. We're now going to play Dr. Kate Jardine's presentation that we recorded on Friday. Kate is a cardiologist for Hunter New England Health. So I'll just do that now. And after we've done that, we'll do a Q&A session on her presentation straight away with Dr. Nicholas Whitehead. So I'll just play her presentation.
Hi, my name's Dr. Kate Jardine. I'm a paediatric cardiologist at Hunter New England Health. And I sit on a board which evaluates any potential cases of myocarditis or pericarditis that occur within the Hunter, New England region once per week. And so today I'll be talking about chest pain presenting in children and adolescents following the Pfizer or Moderna vaccines. The history to this is that in Israel this year, around about the middle of the year, reports started to come out that young teenagers and young men were experiencing pericarditis and myocarditis at a much higher rate than would be expected in a usual year. And there was a correlation made between that and the Pfizer vaccine. And as you know, Israel has very high rates of Pfizer vaccination, or had quite high rates at that time. This data was then seen again in the US, where a similar sort of pattern was seen. And so in Australia, this data was evaluated, and to address this was made. And there's a document which is a nationwide document. We also have a New South Wales wide document. So in terms of the best data we have at the moment is from America, and that data is from the CDC. And that data has said that the rate of pericarditis or myocarditis after an mRNA vaccine, so it's either Moderna or Pfizer, is in males between the age of 12 to 29, approximately 40 per million, which is 1 in 25,000. And in females in that same age group between 12 and 29, the rate has been approximately 4 per million, which is 1 in 250,000. So they're the figures that we're working with at the moment. And this is what I expect to see in the Hunter, New England region. I'm hoping that we mimic this. If that's the case, then between that age group of 12 to 29, we should expect to see approximately 6 or 7 cases in this whole vaccination period. And at the moment, we actually have more cases that we're evaluating than that. And so I'll go through those very, very quickly for you. So at the moment, the committee that I sit on evaluates any reports of an adverse event to a vaccine. And over the last couple of weeks, we've been looking into these cases of possible or suspected myocarditis and pericarditis. In the child age group, we've only had one confirmed case, and that's a 15-year-old Indigenous boy with autism who presented with pain which sounded like it was fairly consistent with a pleuritic pain, had a troponin rise and relevant ECG changes, and he's the only positive myocarditis pericarditis case that we have in that group of 0 to 16 so far. In the other group, which is 16 years and above, there are 41 cases for evaluation at the moment. Only one of them has been a definite confirmed case. That's a 19-year-old male who I'll show you his ECGs and troponin today. And the other 40 cases are still under investigation. I had a look through them last night, and it looks like we may get 1 or 2 that are definite cases. But at the moment, most of these are in line to be evaluated by a cardiologist as to whether they were indeed true cases of pericarditis or myocarditis. So I'll just go on to the next slide here. So this is the case that I wanted to give you as an illustrative case of how I think that we should be approaching these cases. And by and large, the pericarditis and myocarditis that's been seen in Israel, in the US, and throughout the world has tended to be mild and of a transient nature, although there have been some more significant cases. None of the patients have had a mortality event, and all of those patients were treated conservatively with medication alone. And so this case is a case that came from regional New South Wales last week. A 19-year-old male who had chest pain onset 2 days after his second dose of Pfizer vaccine. So already we have a pretty good index of suspicion there, because the myocarditis pericarditis cases tend to occur around about 2 to 4 days after the vaccination. They can occur up to sort of 14 to 21 days after, but usually most of the cases will occur within that 2 to 4 day window, and generally not a lot earlier than 24 hours. So it does take a little while for the symptoms to become evident, whereas we know that a lot of patients present with fatigue, they present with lethargy, muscle pain on the very first day. And so we can use that as a little bit of a way to distinguish this pain around the chest region. So this patient presented with central chest pain. The pain he rated as 8 out of 10, so it was significant. There were no exacerbating or relieving factors. Interestingly, he described his pain as being retrosternal and dull, which is more typical of a myocarditis without pericarditis features. And pericarditis, on the other hand, tends to be that pleuritic pain. And I think the history taking is important. The pain in both these cases should be consistent. It's not the kind of pain that necessarily comes or goes, although it can change with position and with breathing. But a lot of the cases that we've been evaluating in children have been pain for a couple of hours, then no pain, and then pain for another couple of hours, and that's not really consistent with a true good going pericarditis or myocarditis. So this patient was otherwise well, had no cardiac history, was fit and well young man. And so I'll just go on now to have a look at the troponins. So the first point I wanted to make today is that it's all about the first thing is about the history. The history is so important. And I will just mention actually that it's more likely to happen after the second dose of a vaccine, so either Pfizer or Moderna, rather than the first. And some of the evidence for that comes from the CDC, but there have been a few studies into this. So the Boston Children's Hospital have done a recent study of all the cases that happened within the Boston Children's area, and they found 20 confirmed cases of myocarditis, pericarditis in the child age group. And of those cases, 16 occurred after the second dose and only 4 after the first dose. So it's definitely borne out in the evidence that we have so far that it's much more likely to happen after the second dose. So looking at the troponin now, these troponins were actually taken on an iStat machine. So that's the other thing that I think is important to notice. Is it an iStat machine or is it a lab troponin? It's helpful for us at the other end to know about that, because when we're going through these cases later, we don't just want the value of the troponin, but it's good to know what machine was it taken on. And I understand that in New South Wales, in particular in regional New South Wales, there are a number of different point of care machines that are used. I think the iStat's the most common one, but please let us know, was it a point of care test or was it a lab test? So this patient presented for the first time on the 30th of September. His initial troponin was 260, and you can see that was a troponin I. It's measured in nanograms per litre, and you can see there the reference range was 26, so it's far above, 10 times the reference range. And so they appropriately did another troponin a little while later. It may have been a little bit close in this instance. I would have just suggested doing it the following day, but already it had jumped up to 345. He was admitted, and then the following day his troponin went up to 427. So they're not huge numbers, but they're definitely high, and they couldn't be mistaken for a slightly elevated troponin. This is a good going troponin rise in the case of a myocarditis. Now, on the 2nd of October, his troponin had fallen to 161, and so that's a very nice indication to me of the transient nature of this and the fact that he was improving over time. Unfortunately, I don't know what he was treated with at that stage, but what we'll do is we'll go through his ECGs next. So just keep in mind those dates, the 30th, the 1st and the 2nd. The pain onset was on the 30th. So I'll show you his ECGs now. So this ECG here is his ECG on the first day of presentation. So looking through the ECG, you can see sinus rhythm, rate of 102, so it's a little bit quick for a teenage boy. He may have been nervous, but it is a little bit high, and that's good to note. Just looking through, you can see there's a P wave in front of every QRS, so there's no ventricular ectopy. Here, interestingly, does have a bit of a sort of potential partial right bundle branch block on this, which may or may not be relevant. I think, if you look at this, you think, it's probably a normal ECG, but in lead 2, there is a little bit of that scooping, upsloping ST elevation. I think that's just with the eye of retrospect that I'm seeing that there, but just notice what this ECG looks like. So there's only really that subtle suggestion there of an ST elevation in lead 2, and there's not really anything else that's striking about this ECG, but just keep it in mind because this is his ECG the following day. So the following day, he had a heart rate of 72, so as much his pain may have been treated, he may have been calmer at that stage. He's once again got that sort of little bit of a partial bundle branch block in V1 and V2. It's a sinus rhythm with a good going, P, QRS, T. There's no ventricular ectopy there, which is good to know. It's not a we look for that in serious cases of myocarditis, but this is a very good ECG. So yeah, something's going on here with these ST segments. So if you can see, hopefully you can see my cursor. Here you can see that there's ST elevation of about 1 millimeter in lead 2, and again in lead 3, also in AVF. And you can see that replicated in particular leads V3, V4, and V6. Sorry, V4, V5, and V6. And that's a bit more prominent than it was the previous day. Now this ECG, if you saw this ECG in isolation, you might say, well, it's hard to know whether that's a real ST segment elevation or whether or not this is actually just an early repolarization, because we know that in teenagers, benign early repolarization is very, very common. So I think on the basis of this ECG, you couldn't also make a diagnosis. So the whole picture is what we have to take into account. Interestingly, V5, V6, you can see a little bit of notching at that J point. So it could be argued that this is perhaps more likely the benign repolarization, apart from the fact that we know he's got a raised troponin and I'm presenting him at this case. But please be aware of the benefit of serial ECGs, because if it's benign early repolarization, which is common in teenagers, it will be the same day after day after day. Whereas this is so that was the ECG on the day of the highest troponin. So remember, that was the 1st of October. And then this is the ECG from the 2nd of October, which you'll notice already is quite different. So his ventricular rate, once again, is 68. It's sinus rhythm. There's no ectopy present on this ECG. If you go down to your lead 2, you can see the ST elevation is still there, but not quite so much. A little bit of a scooping up of that ST segment. But come over to leads V4, V5, and V6, and you can see that actually the T waves are completely inverted. And so you've got a repolarization change. And this is the day that we had seen the troponin falling again, and this is a sign that the ECG has changed every single day. And so it's not been the same over the days, and so I think this is a genuine case of myocarditis. So we've put this one down as a genuine case, and the point I wanted to make here that it's just so absolutely helpful to have these serial ECGs. And the thing that's not so helpful actually is an echocardiogram. So we've seen a number of these patients having had one ECG only and then referred to us for an echocardiogram. And it does make it very difficult then when we're assessing the cases, because a lot of the time in a mild myocarditis or a mild pericarditis, the echo actually can look quite normal. And so it doesn't give us much diagnostic information one way or the other as to whether or not this is a case of true myocarditis or pericarditis. And so I wanted to put these take-home points here. So I think I've re-emphasized this a lot. Benign polarization in teenage boys can be mistaken for pericarditis, and hence serial ECGs are very important. Secondly, once a diagnosis has been made, an echocardiogram can be helpful in order to determine whether or not there is a pericardial effusion or poor left ventricular function. However, it has quite low clinical utility in helping us to determine a case that might seem equivocal. So if there's a patient who has chest pain, who has a normal ECG and a normal troponin, and with the new guidelines that are out in the emergency department, we should add a CRP and an ESR. If all those things are normal, so normal ECG, normal troponin, normal CRP and ESR, and they've had chest pain, then it all comes down to the nature of the pain and what the ECG looks like the following day, the timing of the onset of the pain, and an echo won't help really at all, because in that setting, it's highly unlikely that we're going to find an echo finding that changes our determination, because by and large the echocardiogram will be normal, unless it's a case of very severe myocarditis, in which case the troponins tend to be very high, so they tend to be in the higher hundreds, in the thousands. And the cases that we've seen so far have had troponins that are in the mid sort of hundreds. And I must say we haven't seen that many true cases, so we'll have more data to gather over time. But the echo's utility is in looking for the sequelae of the myocarditis or the myopericarditis, rather than use as a diagnostic tool. If we do get a definite case and there are rip-roaring troponins and the patient's not improving, then I think we should do an MRI on those patients just to assess where the myocarditis is at. So we use gadolinium enhancement to look at MRIs in those cases, but those cases would have to be admitted to hospital, and quite already we would have the diagnosis. So what I also wanted to say there is that myocarditis and pericarditis is more likely after the second dose, which is a good point, because this week alone, so this week alone, Yasha and I have had a look at 4 cases of potential myocarditis in children, and all of those cases we've determined were not pericarditis or myocarditis. However, they did have the benign early repolarization, chest pain, which wasn't entirely typical, so more of a tightness or not that classical pleuritic type chest pain or the retrosternal pain. And some of those presented after their first dose. And so then the question for us becomes, well, what if we do diagnose this as a pericarditis, what can we give them for their second dose? And in the child age group, we can only give an mRNA vaccine. So we only have Pfizer and Moderna at the moment as options. And so it's quite important that we really pin down, are these true and genuine cases of myocarditis, pericarditis, because it has implications for what we advise in terms of going ahead. So for all those cases that we've seen this week, we've managed to do repeat ECGs, serial ECGs. None of the cases had raised troponins, and we went back over and took a good history of the nature of the pain. We did a Holter on one of the patients. We've ended up doing echoes on most of those patients, which have all been normal. And so we've been able to reassure those patients that they can go ahead for their second dose of the Pfizer vaccine. So that's helpful for us to have this information. The other thing is that it would be good for the reporting to the AEFI, which is the Adverse Reactions Committee, to know whether the troponin was done on a point of care machine or whether it's a hospital troponin done in the lab. We want to know, was it a troponin I or a troponin T? And if the troponin is elevated, then I'd like to have a series of troponins, because I'd like to see what's happening to that over time. In terms of these cases, a lot of them will present to the pediatric emergency department or to the GP. I'm more than comfortable for most of these patients who are well to be managed in the GP in terms of getting an ECG, and if possible a same-day troponin, plus ESR and CRP. The ESR and CRP can be reserved for whether or not we have quite a high clinical suspicion. If the patient comes back with a high troponin or ECG changes that look like myocarditis, Yasha and I are both happy to take a phone call. We'd much rather consult on these patients than be doing it all retrospectively as we have been this week. So we're open to taking phone calls on any cases once they've had these investigations done. Similarly, if a patient is found to have ECG changes in community, they've got a high troponin, then please send those ones up to the pediatric emergency department for serial measuring, and we can go from there. So the ones who are a definite case and a little unstable, send up to the ED. If they look like a definite case but look very stable, we're happy to take a phone call. In terms of treatment, I tend to use Nurofen. Aspirin can be used as well. So NSAIDs, aspirin, or Nurofen for 1 to 2 weeks, and then we have to watch the symptoms and continue that until the symptoms resolve. In the case I showed you, it may take 3 days. It could take up to 1 to 2 weeks for the symptoms to resolve, depending on whether it's a pericarditis, myocarditis, a combination of both, so myopericarditis, and really how significant the case is. Now, I see that quite a number of the adult patients in the 41 cases that are awaiting evaluation for whether or not they were definite cases, I see that a number of them have been prescribed colchicine. And so in the practice with children and adolescents, we tend not to use colchicine in these cases of a transient pericarditis. The evidence for colchicine seems to be a little stronger for recurrent pericarditis, and I understand that it's used a little bit more widely in the adult community. But I would say that in these situations, there hasn't actually been any reports of these cases of vaccine-induced pericarditis or myocarditis being recurrent. And I know we only have data from the middle of this year, but so far they've been one-off cases that have all resolved with a simple and short course of simple Nurofen, aspirin, fluid intake and rest. So I think in regards to colchicine, we certainly won't be doing that for any of the children or adolescents less than 16, and I'll leave that up to my adult colleagues as to whether they would like to advise that. But from my point of view, the simpler the management, the better. So yeah, we're happy to be consulted on these cases. It's always much easier to pick up the phone, and Yasha and I are both happy to talk through any of these cases. We've got a pathway coming out, and there's a GP pathway, and there's also an emergency department pathway, which is a national guideline, and that's been put together due to the fact that this has become an issue throughout all the jurisdictions in Australia, and particularly in Melbourne and in Sydney. So I'd like to leave it there. If there are any questions, one of my colleagues will be available at the end to answer any questions. But yeah, I'm more than happy to be consulted on these cases. I'm really passionate about getting these diagnoses correct, because one, it allows for the second dose to go ahead if there's any query about the second dose, and secondly, it does really matter for our data. So we want to know that we've got accurate data that we're going to be able to gather at the end of this vaccination period, because we may end up in a situation where people need to go forward for third doses, and we need to make sure that they've had a definite case of myocarditis or pericarditis before making that determination. So thank you very much for your attention and interest in this topic, and thank you once again for your hard work throughout the pandemic.
Okay, I think we're going to have some Q&A now on that presentation. I believe Carolyn is going to do that. I'll hand over to you, Carolyn, and Nicholas, if you could put your camera on, that would be great.
Hi, Nick.
Hi, Carolyn.
I think the questions that I've got are actually all interrelated, so I think I might ask them as one, if that's okay. So we're seeing quite a lot of patients who have got non-specific chest pain and we just, I suppose, need some advice from a general practice perspective around how much can happen in general practice, and how much, when do we need to do troponins, when do we need to do an ECG, I think would be helpful.
Yep. So it is a tricky thing, and particularly after the first dose and all the issues for going ahead with the second dose. And certainly there do appear to be a lot of people presenting with some sort of chest discomfort, often as part of a broader syndrome of just being achy. I think the important things about the history are pericarditis has a very typical pattern, and the pain from pericarditis does not really vary much. It's a pain that is worse with respiration and changes with position, usually, you know, from lying on your back to being up and forwards. There's a distinct change, and it's a sharp stabbing sort of pain. And it's pretty rare to see someone with pericarditis that doesn't have a pretty typical pain story, at least in other causes of pericarditis. So the pericarditis really, I think, is one aspect. Myocarditis pain is less definite, less well defined, and can be just a diffuse discomfort in the chest. Sometimes people have myopericarditis and have a bit of a mix sort of thing. I would suggest, look, for most people who are presenting and a prominent complaint is chest pain, you know, they're saying, I have chest pain after their COVID vaccination, and you're asking the question, I think doing an ECG and a troponin in the community is reasonable and appropriate, and then reviewing the results of those. The myocarditis patients that have been, cases have been published after the mRNA COVID vaccines have had positive troponins. And the largest paper, I think, is from Israel, and it's 54 cases, you know, out of many millions. And all of them had positive troponins. There's always a question of case definition, but without doing endomyocardial biopsies on every patient that has a COVID vaccine, we're never going to get a you know, absolute answer on that. But it seems to be a reasonably clear syndrome where they do have a positive troponin in the case of myocarditis, and have dropped. It has a much troponin has a much greater sensitivity for myocarditis than doing an echo, for instance. So if the troponin is normal and undetectable, then I think the chance the patient actually has myocarditis is vanishingly low. And ECGs, you know, I think, you know, ECGs are cheap, harmless, and they're actually useful to have them for people's background for comparison. It would be nice if everyone had an ECG of a certain age and we could compare them, but it's not feasible to do it for 20,000 to 100,000 people for every one case that we're going to see. So I think the PHN pathways hopefully going to address this fairly clearly, but basically cardiac symptoms including chest pain, exertional dyspnea, or suggestive palpitations should get a history, physical examination, ECG and troponin. And I think the physical examination should be highlighted because we often skip over it, but patients with significant myocarditis should look sick and have an abnormal physical examination. If they're a patient who actually has a high risk myocarditis, then things like tachycardia, raised jugular venous pressure, crackles, you know, sweating, low blood pressure, they should appear sick. And I'm sure that many of cases of this mild myocarditis have been ridden out at home without seeming lasting problems early in the phase before this problem was sort of recognised.
In the Israel study, did they all have abnormal, or do we know about their vital signs? Because I suppose that's actually pretty important, isn't it? Do we know?
I don't know. They did have not much in the way of fever, and the blood pressure was okay, but most of these patients had, again, mild myocarditis, and so there's only one who had what, you know, we'd call fulminant myocarditis, and they had a bit of a complicated history. So I mean, the major concern should be, you know, is the patient going to have a bad outcome, and some of those basic clinical things are better judged than doing a test like an echo or not. Is the patient sick or not? And if the person is not sick, if their exam's all right, they're not too concerned from the end of the bed sort of thing, then I think evaluating them in the community and using troponin and ECG as extra information is appropriate.
The other thing Kate mentioned was under 29s. Has there been any cases over 29? I suppose it starts to get tricky when people get older to determine the difference between ischemic heart disease and pericarditis, myocarditis.
Most of the questions I'm seeing are patients who have had palpitations and or arrhythmia, and it does get quite tricky because and also if they have myocarditis, the rate in the studies is fairly similar in those who have had vaccination to the background rate of myocarditis or pericarditis in the population over that sort of age group. So I have seen a few patients who have had lots of problems with palpitations and non-specific chest pain, but have had normal troponins, and the ECG's been fairly unremarkable. And so they're fine from it. They're not going to suffer from this acute event. Basically, it's more a question of should they have a second or third dose of mRNA vaccine. And as my understanding at the moment is not giving another dose of mRNA vaccine is out of a cautious approach, which is quite reasonable, but is not out of proven harm, but is, you know, if we caused a problem with the first dose, maybe we shouldn't with the second, or second with the third. And yes, like I had a lady the other day who's 50 years old, had a lot of non-specific symptoms after her first dose of Pfizer, and then eventually she had a run of atrial flutter captured on her like 8th or 10th ED visit. But she's obese probably with obstructive sleep apnea, and her flutter may be, you know, incidental to the thing. So that does become difficult. I think coming back to, at the moment, troponin is probably a very good stratifier, as well as serial ECGs for comparison, because a lot of people have a vaguely non-specifically abnormal ECG that stays the same.
The next question was, Kate mentioned doing a CRP and an ESR, and I just wondered, why do we need to do both? Can we just do one?
Yeah, I mean, if you're just going to do one, do a CRP, yes. So yes, why do we do both? Well, probably it's not that sensible to do both in a condition like this, but we don't know for sure. And so there are different, you know, in general inflammatory conditions, there are differences in who manifests as CRP or ESR. And so there are unknowns, you know, this is a recently defined condition. And so, I mean, it doesn't cost that much extra to do an ESR on top. So yeah, I mean, I'd probably end up ordering both, but the CRP is more likely to be helpful. If you're going to order one, I would do a CRP.
I think ESR is quite a lot of work in the lab. It's quite a time-consuming test and pretty manual. So yeah, so CRP is probably the easiest and most sensible. I'm just going to hand over to Sandra. Any more cardiology questions for Nick before we say goodbye?
There certainly are, Nick. Have you got a couple more minutes? I know you had to leave.
Yeah, I can, yep.
Okay, great. And so a really good one, which I'm interested in myself. Moderna's recently been suspended for the under 30s in some Scandinavian countries due to the much higher incidence of myocarditis, pericarditis compared to Pfizer. Yet it's being given freely here via pharmacies, and the issue hasn't been widely publicised here. Do you think we will follow with this restriction?
I don't know whether or not we will follow with the restriction. I mean, different countries have had different thresholds for interrupting and suspending vaccination programs with, to my mind, you know, significant potential public health impacts, like the suspension of AstraZeneca in some European countries for a period that was probably excessive and resulted in a great deal of extra vaccine hesitancy. So I don't know the answer to that. We always have the challenge that the more we warn people about side effects and dangers, the more people become concerned about them and run into non-specific symptoms, which is always a tension, the nocebo effect. And I think we're seeing a lot of that now. I think the ED department is seeing a lot of that, and certainly we're seeing a lot of it in rooms. That so that's a a difficulty. But at this stage, I think the benefits of vaccination, I know I deal with adults, but the benefits of vaccination are clearly vastly more than the risk for all available vaccines.
And interestingly, Nick, when you look at the absolute differences, it's not huge. Like for myocarditis for Moderna versus Pfizer, it's 28.3 per million doses versus 7.4. So not big absolute numbers.
Yeah, it's pretty hard to draw that much.
Yeah, it gives me the opportunity to plug the newly publicised health pathway that went live today, which has got those differences in figures in it. One more question for you, Nick. How long would troponin stay elevated, for example, 3 weeks after first patient presented for second dose and discloses chest pain then?
I'm not sure we have the data on that from enough cases to be sure. The length that the troponin stays elevated does vary in different conditions, in a myocardial infarction versus other conditions. But I would, if someone's had a troponin of 200 or 300 in a short lived condition, it may well have gone down fairly low. Can you guys still hear me? Sorry, it just froze there for me. Hopefully I'm back.
You are.
If the troponin is undetectable and it's 3 weeks, like less than 2 or less than 3, whichever lab is used, and it's less than 3 weeks, or it's 3 weeks since their first dose, I would think it is very unlikely that they've had a significantly elevated troponin. As it takes a while, and as Kate showed, in her case, the troponin will stay up for some days, and then it takes a good week or more for all of that to completely wash out. I think the chance is very low, and unfortunately, we don't have, a way for sure of going back in time and finding out for those patients who have presented late saying I had symptoms at this point in time, but the rate of myocarditis after the first dose is incredibly small, and so if the troponin was undetectable, I would say just go ahead.
And just one very last question, which I don't know if this is one that you can answer, but it's from one of the GPs asked, said, thanks for the offer of consults during office hours. Do we ask for the paediatric cardiac consultant on call directly, or is there a registrar to discuss this with first?
So at the John Hunter, no, there's no paediatric cardiology registrar that I know of. So it'd be the peds cardiologist on call for the paediatric patients. For the adult patients, it's if you want advice, call your favourite cardiologist, I think. And that's probably a better way of doing it than trying to speak to the advanced trainee at the John Hunter, who I know they're incredibly busy anyway, and are starting to get a lot more calls and questions, and it's probably better to find a cardiologist who'll answer a quick phone call. I know I've certainly seen a number of referrals for patients like this that have fortunately, included investigations, and I've basically just responded saying to the referral, rather than patient waiting to see me, that this is my advice. And other bits of information to plug apart from our pathway is the Australian government does have some good, fairly brief documents including guidance on myocarditis and pericarditis after mRNA COVID-19 vaccines, that do have a fairly concise summary of the current state of play, with the biggest question mark still being, what do we do about patients who we think really may have had myocarditis or pericarditis, and the advice or outcomes on that, as in what we should do for then repeat vaccination is currently lacking, unfortunately.
Thanks, Nick.
Jenny, it's Carolyn. I think maybe we should go straight to SAFE next, should we? And then have questions.
Yes, that would be wonderful, Carolyn. So, SAFE, if you could turn your camera on. SAFE is a GP from Abermain Surgery. So I'll let you take it away.
I think you're on mute, SAFE.
Can you hear me now?
Yes, we can.
That's good. Thanks, SAFE.
That's all right. So, thanks everyone. I'm just going to talk about the vaccine complications that we've been seeing of late, and in my role as a GP as well as an emergency physician, I kind of think of both parties and how each one of them think, and I completely feel for them both. Really, it's a pretty hard gig. So I'm just going to talk briefly on how we're going to try and help not sending these patients down to ED and waiting for excessive hours and perhaps to get told just go and follow up with your GP the next day, which has been having quite a lot of late as well. So I'm going to talk mostly about the AstraZeneca and the Pfizer. I'm not going to talk about the Moderna because it's been just rolled out to the pharmacy, and these patients tend not to come back to us for an advice after that. So with the AstraZeneca, we have the VIT, which is the vaccine-induced thrombocytopenia thrombosis, and the Pfizer, which mostly goes in cardiac issues. So for both vaccines, they also cause generalized and localized reaction, plus the known side effects. Unfortunately, the media has played a very bad role in that, and it's just blew it up big time. So both AstraZeneca mainly has gained a very bad publicity because of that. The patients struggle to get it. Yeah, hopefully that's changed a little bit now. Now, something good that's as the vaccination rate goes up, and we're pretty much vaccinating a lot now, and reaching 76.5, I think, % today double vaxxed. So hopefully going to be seeing less of these post-vaccine complications, but that might change in the near future, where the kids between 5 and 12 can start getting vaccines, and the third dose of the vaccine is going to be rolled out. And in fact, I did 2 patients today, 3 for the third dose of the vaccines as being instructed. Okay, so I'll talk first about the AstraZeneca and the with the generalized and localized reactions. So how can we minimize that? The first statement I open up any consent when I consent my patients to vaccine, that this vaccine is pretty safe and an effective vaccine, whether it's the AstraZeneca or the Pfizer, just to try and ameliorate their anxiety. And if I can see them quite anxious and hesitant not to have the vaccine, and they've been pushed by their employer or by their family to come and have it, I said, look, let's talk about it and let's see what concerns you. They'll start talking about all the Facebook videos they've watched and the articles that their friends have sent. So it's not to educate them about it. So look, I've had Pfizer myself. My wife had AstraZeneca. I've vaccinated my 14-year-old daughter with Pfizer, and that starts kind of ease. I can see them getting more and more comfortable with their conversation and going ahead with it. Now, I usually ask my receptionist, as they wait for me to call them in to get the jab, they get handouts about the vaccine and what to expect of the vaccine before I get to see them. So they get handed out the paperwork while they're waiting for me for 10, 15 minutes or whatever time they can wait. They go through the paperwork, and as they walk in, I see that they went through the hand sheet of what they should expect from the vaccine, whether it's just a redness or reaction or lump or feeling achy, or and we just explain all that to them. And I just thought, look, just take it easy for the next 24 hours, which should be sweet. And then I'll tell them, look, if you have any issues, I'm here tomorrow. If I'm not here, my colleagues in the practice are here tomorrow. Just give us a call, and we'll fit you in to see, or we can explore it over the phone. And sometimes the receptionist come to me and tell me, look, this patient's called with this. So yeah, just put her on. I'll talk to her for 2 minutes. That's fine. Just rest it and take a photo for the rash or for the lump and send it over to me, and I'd apply back, or I offer to see them in person. Most of them think that they have cellulitis, and I've seen quite a few patients that have been prescribed antibiotics by other facility for a reason or another, but in fact, most of them are just a reaction to the vaccine, just an immune response. So, yeah.
We can't see your slides.
Ah, sorry. Can you see them now?
Yes, we can.
Ah, sorry. Okay. Yeah, so this is the first slide that I was talking about. Yeah, there you go. So we talked about the AstraZeneca and the Pfizer, the complications, and how to minimize that by patient education and the hands out, so they can see them before they walk into the vaccination room. And this document that I'm going to go through is developed by the THANS, which is the Thrombosis and Hemostasis Society of Australia and New Zealand. Now, in brief, the VIT, which is mostly the AstraZeneca, and every patient walks in, is it the AstraZeneca, the clots vaccine? Because this is really what they know about. It's the clot, it's the clots. And as I think Chris pointed out, the problem is only 125 cases out of the millions and millions of vaccine we've given. And we have 8 deaths from them only. So that kind of, okay, that's not too bad, not as bad as I thought it would be. And as we all know, it's 4 to 42 days after the vaccine, whether it's the first or the second dose. So we have to have few criteria to fulfill that. That's the thrombosis, with probably initial platelet count can be normal, but can drop very quick. So the platelets should ideally be less than 150. And the D-dimer, which I'm not a big fan in my emergency life. As we know, it's not specific enough to guide you through any path, but it's sensitive enough to rule out any thrombosis if it's negative. So with the D-dimer, it has to be 5 times more than the upper normal limit, which is 0.5. Now, D-dimer is usually elevated in most people, especially the elderly. But it's not going to be, hopefully, 5 times upper normal limit. Just be mindful of that 5 times upper normal limit. If the patient is acutely not unwell enough, then we're happy to manage them in the community. We can investigate, and that's a teamwork. So most of us GPs now, talking the community, have very good connections with pathology providers who could well be in the same facility as we were, and the local imaging place, and we can ask them to do an urgent imaging for a limb if we need to rule out the DVT because of that, or we need to organize urgent blood tests. And then I, for example, have Laverty in my practice, and if I need urgent bloods, they organize Curie to pick them up, and I get called with the results, so I can log in from home to chase the results. Ideally, we need to have the results back in 4 to 6 hours. Okay, now, if we have isolated thrombocytopenia, then it could be vaccine-associated immune thrombocytopenic purpura, which I haven't seen so far, but something to keep in mind. Now, what do we do with AstraZeneca? So we can send for full blood count, APTT, PT fibrinogen, and D-dimer. And again, we need the results to be within 4 to 6 hours, because it's something that you don't want to sit on for a day. And I completely get it that in general practice, Friday at 5 o'clock, had a big week, you want to go home, and I've been that so many times, and a patient comes in or rings up with these problems. It's probably not the easiest thing to deal with in the community. I completely get it, and unfortunately, some of these patients have to go to ED. We know that a lot of patients have no threshold, not low threshold, to call the ambulance and go to the emergency department for any reason. And that can cause a lot of problems in terms of access and clogging up the emergency department ambulance bays and potentially delaying life-threatening treatment for patients who really need them. Okay, now this is screenshots from this document. So obviously, unlike any other thrombosis, we don't want to give them any heparin or low molecular weight heparins. So I need to get these bloods done and ideally have them quick. Now, the D-dimer, which is the main player here, less than 5 times of the upper normal limit, then we can rest assured that it's probably unlikely that this patient have this clotting syndrome from this vaccine. So we need to think of something else. Now, let alone all the AstraZeneca patients, or most of them, in the elderly age group, who are already at high risk of having thrombosis and all these complications. So we don't want to mix them up with vaccine-related problems, and we want to manage them accordingly. So we can manage the DVT as any other DVT in the community. We anticoagulate them, and we see them or get the request form for the imaging to have it the next day. Now, the second group who are in between pretty much, where the D-dimer is more than 5 times upper normal limit and normal platelets. Now here where the platelets is going to be a problem, where they can drop within 4 to 6 hours. So we'd like to repeat them bloods in 24 hours and see what's happening. If they're not sick, again, we can sit on them and follow them up from our end. Now, this is the sick group, or potentially sick group, where the D-dimer is more than 5 times the upper normal limit, and the platelets counts below 150. Now we need to organize urgent imaging according to the site that we think they might have the vaccine. They have severe headaches with symptoms suggestive of blood flow obstructions, i.e. stroke mimics, that we need to think seriously how we're going to manage them. Are they appropriate for the community or not? And those are the patient cohort who could be appropriate to be referred to the hospital. Again, that's just to finish off that algorithm, which is pretty nice, and it's available at the Community Health Pathway of the Hunter New England Health. It's very nice, user-friendly, and I think it's quite clear to me at least. Again, we talk to the hematology, or we can send them to the hospital to be managed there, because it can be potentially bad. But most people, again, as you've seen from the data, has a very low mortality rate. Now, briefly, I'm going to touch on the Pfizer. My colleagues have done a great talk about it, so I'm not going to really add much more than that. The pericarditis and myocarditis, so they usually happen within the first 5 days after the vaccine, or again, first or the second dose, can happen in kids, but the prognosis is generally pretty good. And I think we might be seeing more of that as we start vaccinating the kids between the age of 5 and 12. And my friends, a couple of pediatricians in the United States, have already started doing pediatrics group. Again, the symptoms are quite classic: chest pain, palpitations, shortness of breath. We like to examine those people. So we need to listen to the chest, we need to check their blood pressure, postural blood pressure, heart rate, and we make sure they're perfusing well. Reason is, with pericarditis, if we want to rule out the pericardial effusion, then we want to make sure that they're not tamponading, that is not compromising their flow. So are they, and now we have few elderly people, or not elderly people of the age of 50 or 60 who start to have the Pfizer, and I had people myself in the 80s who had the Pfizer. That we want to make sure they're not seriously or acutely unwell. So I'm going to make sure that blood pressure, even if it's 120 on 80, for someone who's always hypertensive and their blood pressure always in my room sitting at 160 and 90, that's probably low for them. I just want to make sure there's nothing else going on for them. ECG is pretty quick and straightforward that we can get done in our surgeries. Most of us have nurses, and if I don't have nurses, I have wonderful registrars who actually do ECGs themselves. Echo, if I personally have, again, requested echoes, so I pick up the phone call of the local cardiologist to say, hey, got a guy here with probable pericarditis or myocarditis, can we get an echo? He's day 3 post his Pfizer vaccine, and they squeeze them in. They squeeze them in, and they usually are happy to pick up the phone and talk to you about them. And obviously, with the troponin in myocarditis, we don't tend to see troponin leak in pericarditis, but certainly in myocarditis. And most of those people pick up pretty well. I had a patient last week who was day 5, I think, post, or day 4 post his Pfizer, who had presented, who had chest pain a couple of days before that. But on the day that I saw him, he had nothing, no chest pain, it had resolved. We've sent him home. We didn't do nothing for him. He was fine. His pain has resolved. I didn't really need to do much. I think that is pretty much all what I have really about these 2 vaccines.
That's great. Thanks, Safe.
That's all right.
Can everyone turn your cameras back on, please? I think we haven't got very much time. I've got a few questions from Sandra that maybe I can send to you, Mike. I think that's more around the logistics. So one of the challenges for hospital in the home patients is that the GPs actually can't charge for them. They're not allowed to see them because they're actually, they are allowed to see them, but they just can't be paid for it. So there's some logistic issues around MBS and federal versus state challenges with hospital in the home. So maybe that's something that the hospital in the home team need to think about in terms of general practice involvement.
I know there are a bunch of GP VMOs that are working with Mark Lowenthal's team at the moment. I'm not sure how they're getting paid.
Yeah, I think they're getting paid because they're employed as GP VMOs with the hospital system. But the challenge is that a GP can't see a patient in their rooms and charge an MBS item number while they're a patient of the hospital in the home service.
I think Sharon Ryan's going to try and grab some of the GP VMO time for paediatrics as well.
I think that was one of the things. And then the other issue, it sounds like there's a lot of interest in the respiratory pandemic clinic, and I think probably those questions or interest probably needs to go to the PHN in the first instance so that the names can be collected and then passed on, I think any other questions? And the other issue is just around access to mental health, as we know in the ED, but also in general practice. There's a significant problem with access, even in private psychiatry, of seeing a psychiatrist urgently in Newcastle. As well as the increasing levels of anxiety and mental illness in the community, there's also increasing lack of access to those services as well. So in some ways, the ED is feeling the pain of the system that's not got adequate workforce to manage. But even the
access they've got some often online, on screens, and ironically, a lot of teenagers would prefer face-to-face, I gather. All right, but that's sort of less satisfying.
Yeah. Any other big questions there, Sandra, that we need to ask us? We're just about at 8 o'clock.
We are just about at 8 o'clock. Very quick one. Does anyone know if eventually we give 5 to 12-year-olds the vaccine, will there be paediatric doses? I think I heard a rumour that there was. Does anyone know? No, this is probably not the right audience.
No.
And the one question, who do you contact for the COVID clinic, which is, I'm assuming, GPs interested in being GP VMOs with either the adult or paediatric COVID clinic. Mike, would you like that in the first instance to be the Health Pathways team because we've been liaising with them, or would you like them to contact anyone directly at the hospital? Or
you mean the pandemic assessment clinic?
No, maybe the pandemic assessment clinic. Either that or working as a GP VMO for.
I'd contact Leanne Johnson for the pandemic assessment clinic, and for hospital and home, probably Mark Lowenthal or Sharon Ryan would be the two people I would have thought.
Yep, great. All right, and if anyone wants those contact details, just shoot us some feedback via the Health Pathways and we'll be able to point you in the right direction. And just a quick plug for Health Pathways. As I said before today, we did make live our myocarditis and pericarditis after mRNA COVID vaccine pathway, which many fine gentlemen on this screen had some input into, as well as Kate Jardine. So have a look at that because everything that was discussed tonight is outlined there quite clearly. And we also do have the vaccine-induced thrombosis with thrombocytopenia syndrome pathway, which again outlines everything that was discussed, and Anoop gave a great presentation on recently. And we've also got the step-by-step process directly from the public health unit, our local public health unit, on reporting adverse events following immunisation. And so really would love you to go to that a vaccine referrals reporting and advice page to follow that step-by-step process because it's slightly different to the New South Wales health process. And thank you to Rebecca Johnson, who I know is listening, for all her work on that with us.
Thanks, Sandra. Any comments from you, Anoop, because we haven't actually heard from you. So thanks for sitting through the talks today. We really appreciate it. But any comments or any thoughts?
No, not really. Thanks, Carolyn. I think we've obviously VIT is now on the downtrend, given that the majority of the vaccinations are now either Pfizer or Moderna. So I haven't consulted on a patient with WIT who needed a hospital admission for several weeks, which is a good development, I think. But otherwise, yeah, I did have a presentation like Sandra mentioned, I think about 8 weeks ago or around that time. So people are welcome to go and have a look at that. There's been a few updates from there, but majority of the content should still be applicable.
Excellent.
Thank you. Thanks once again for having me here.
And hopefully one day in the ED we'll get to order much less D-dimers again and return to a sense of normality. But anyway, any more comments from anyone else on the panel? Thank you all for presenting tonight.
No, just great. Thank you very much, and thank you for organising.
Thanks very
much. Thanks very much, Carolyn, for looking after facilitating our questions. And I'd like to really say a big thank you from the PHN education team to all of our presenters and giving up your very precious time this evening. There will be an evaluation that will pop up immediately following this webinar, and we would love to have your feedback. And Anoop's presentation that was about 8 weeks ago is in the education library on the PHN website. All right, thanks everybody, and stay safe.
Thanks, Jenny. See you, everybody.
Thank you.
Right.
Bye.
You guys.